Welcome to episode 118 of the Urology Coding and Reimbursement Podcast. I'm your host, Scott Painter, with my co-host, Mark Painter and Dr. Ray Painter. And this episode, we want to welcome back Dr. John Lynn. Dr. Lynn is a private or a solo practitioner in Gilbert, Arizona, which is in the Phoenix area. And today we want to cover a couple questions that came in to the Thriving Urology Practice Facebook group, which Dr. John Lynn started and is the moderator for, and it's free to join. And John, do you want to share a little bit about the questions that we got and also about the Thriving Urology Practice Facebook group? And welcome. Thanks for joining us.
Well, thank you again. It's always great to be here for the opportunity to share what little I know. The Thriving Urology Practice Facebook group was born out of frustration in that there's not much information out there when I started it many years ago about urology and urology-specific information, specifically in the United States. So it's a free forum where any U.S.-based urology practice folks can join. So we have C-suite people, we have physicians, APPs, we have a lot of billers and coders, MAs, marketing folks, and things like that. So we kind of vet you with a simple questionnaire, and then we bring you in. We have almost 2,000 members in that group, and it's very active. That's the thing. And today's questions came from that group.
Excellent. Great resource. A lot of great information going on in there. So we do encourage you all, if you haven't joined, go to Facebook and find that group, the Thriving Urology Practice Facebook group. We'll put a link in the episode page. So if you go to prsnetwork.com/118, you can get a link to that as well. All right. Let's get started. John, what do you got for us?
All right. This was a question about the viability of a pre-op clinic that was proposed. And the question reads like this. Is it possible to have a billable preoperative clinic visit with an APP before surgery, but after the visit where the decision for surgery has already been made? The proposed purpose is to make sure clearances and cultures and blood work are done before the patient's urologic surgery. I thought this was bundled already and that this type of visit would not be billable encounter. Thanks for your insight. And of course, that raised several responses from people, which I don't think were correct, but let's hear from the experts.
Okay. Thanks, John. You know, we've definitely talked about this question several times in our seminar over the years, and whether it's been virtual or live or everything else, it's an ongoing question. And you know, when we look at the actual definitions of what's included in the global from CMS. You know, the real global period for a 90-day global begins the day before the surgery, and the global for a 0 or a 10-day global period or procedure is the day of the procedure, and that's it, as far as the preoperative period. So when we look at the potential of an APP, and we have to look at it in the spirit of everything that Medicare has kind of put out there. And when they shifted the shared split visit rules, I think it was last year that they really started focusing. Maybe it was 2021. It was 2021, right? That they, in that decision for the shared split visit rule, they really made an effort to classify the mid-levels as the same specialty for whom who was employing them, if it was a single specialty group. Even though they have different taxonomy numbers, what they were trying to do is extend out that, in fact, the employed APP was another urologist functioning within that practice. So the way that you need to look at preoperative visits really falls along the lines of, if the physician that is performing the surgery was doing the preoperative visit, would it be billable? So when we look at those issues, and we pop in the global period, we know that any visit that is provided the day before a 90-day or the day of a 10-day global, after the decision for surgery, is not billable unless you're on the same day and it's a significant separately identifiable E&M. So it's not related to the procedure. So within the preoperative global, that would be a no. That preoperative clinic wouldn't work. But as far as billable, but if we look at it outside of the global, there are a couple of ways to report it. Whether or not you're going to get paid for it is a separate issue, but you have to report it accurately. And that really means that, all right, you're outside the global, so you don't need a modifier. But you do need to add an appropriate diagnosis code to that visit to indicate that it was, in fact, an encounter for preoperative or pre-procedural exam. And in most cases for urology, that diagnosis code is Z01.818, encounter for other pre-procedural examination. So if that is the primary diagnosis with the E&M that is provided on that particular date, that would be reportable. But whether or not it's payable is going to depend on the payer. Your second diagnosis would be the reason for the surgery. So those are all important things to make sure that you have in place. Now, there are some other Z01.81 codes for cardiovascular exam, laboratory exam, and for the respiratory examination. So if there is a specific event that needs to be done and it hasn't been provided by somebody else, so a primary care doc didn't do the clearance for those, and your APP is doing those specific clearances because of underlying conditions, which you'll also need to document and report on the encounter, you can use some of those other diagnosis codes. But in most cases, what I see, Z01.818 is the correct diagnosis that would be first on the list. But remember, this is not a visit that could be modified just because it's being done by your APP, who really is, in most urology groups, an extension of the urologist.
So the bottom line is, in this scenario, as presented, that visit, that pre-op clinic visit by the APP should not be a billable procedure.
It shouldn't be. It is. I mean, it is one of those areas where timing is something to consider, but it is one of those that if it's within that day before, absolutely not.
What if it's
outside,
not the day before?
If it's not the day before, again, reportable from the standpoint that you're outside the global. But it is one of those things where you're going to have to justify the medical necessity for that. Doing it a couple days before, and you're going to have some issues potentially with the payer that really decides whether or not they're going to allow for that preoperative visit, and it does need to be coded appropriately.
So let's go back to the scenario. There's a pre-op clinic for this practice where the APP oversees all the pre-op patients. The decision for surgery has already been made. The patient comes back, the APP looks over all the pre-op clearances, maybe anticoagulation management, clearance by cardiologists, clearance by pulmonologists, and then urine culture results, and then any hematologic workup, and then says, okay, do you have any questions? Can we answer any more questions regarding your surgery, your perioperative course? Now, this visit is occurring not within the global period of the surgery. It's not the day of the surgery, it's not the day before, but sometime between the actual surgery and the decision for surgery, but not within the 90 plus 2 day, for instance, of a major surgery.
Yeah. I mean, it's one of those weird loopholes that says it's not in the global, right? But you're definitely looking at a spirit of the law versus the actual regs that I think is going to get looked at very hard within the payer realm to say, why was that, really truly necessary to be billed outside of the global period? Because that global visit or that global package was intended to include that. So,
well, hang on now. The reason
but
that,
I am,
the reason that is necessary is because I can't just say, well, I'm going to do a cystectomy on this patient and then do the pre-op labs and then the next day go to the OR. I have to get clearances from other specialties who may or may not manage their anticoagulation and stuff like that. And then the patient is made to come back in this situation in a pre-op clinic to go over all these things and answer any additional questions.
Yeah, it is one of those areas where you're outside the global. The correct diagnosis code reporting would say, yep, this is a pre-procedural visit and I'm outside the global. So I'm giving the payer all the information and I didn't need a modifier to do that. So reportable, as I said, but I don't, one of those areas where whether or not it's payable and how the payer's going to handle that is a different issue.
Well, have you seen any that are paid or that are not been paid? Or have you tried billing it? Or have you ever seen anybody bill it?
We've seen them paid.
Okay, so in this situation, if it's outside of the 90 plus 2 day, so it's not the day of, it's not the day before, you're seeing the patient in a pre-op clinic when you use the correct reporting Z01.818 ICD-10 as the primary diagnosis. And then the secondary diagnosis may be bladder cancer, muscle invasive bladder cancer of the posterior wall. If you report it appropriately in this situation and the payer decides to pay you, then that's really on the payer. I'm telling the payer that this is an encounter for other procedural examination. It's technically an okay thing to do and technically a billable type of a thing. But within the spirit of the law of the global, you're saying that it may not be.
And that's where the payers and their rules and their interpretation is going to be an interesting piece. And I know there have been at least a couple of payers that are extending the global period out well before the Medicare piece in a soft edit. And so you will see denials with that.
For the astute coder and biller, they may just flip the diagnosis codes around. They may say bladder cancer first and then use the encounter for other pre-procedural examination code second. Maybe, and then they'll try to push that through. I'm just talking realities here. Realities.
Yeah. I mean, the primary reason for that visit is pre-procedural. That needs to be the first diagnosis from a coding standpoint. So if you're, and you need to map your payers and understand where their rules are and try and see where your contracts are as to what's allowed and what's not allowed within the contract. That's exactly what we're doing. But as long as we're upfront in our reporting, and we're following those rules, we're not reporting an event that didn't occur, and we're not reporting an event that wasn't medically necessary, and we're not required to use the modifiers for those particular events, then we should be good.
Well, this is one of those areas where I think we have to drop back to medical necessity. And if you're doing this on the complicated patient like John is talking about, and you're doing it outside the global, it absolutely should be paid, because there probably is other medical necessity for checking cultures and that sort of stuff other than just pre-op. But let's put it back in the proper perspective. When Mark says culturally or what should be done, he's probably referring back to the ACS, American College of Surgeons, original bundle, which was followed until Medicare set up their new rules in 1992. And on those rules, they decided since you're being paid by a computer, they couldn't handle whatever was done at some time in the past as a guideline for when to pay you for another visit. So that's when they set up the day before and the day off for the 90-day procedure. So Medicare at that point said, we'll pay you for any visit that you have before the day before. But, from the spirit of things, you should not bring anybody back for a pre-op or anything like that unless it's absolutely medically necessary. But if you're paid by a computer for Medicare, odds are you're going to be paid, right?
Yes. Now, here's another scenario. Many hospitals and surgery centers require an updated HMP within 30 days of the surgery. Now, I think if you were to bring the patient back into the office and build that event solely just so that you can do a pre-op HMP to satisfy the surgery center or the hospital's requirements, then I don't think that's a payable event.
So I would have to agree with you. And actually, under the new rules, the H&P on its own isn't really a medical decision-making piece that fits into that category at the same level, because you're just doing an H&P to check the boxes. So I think there's two reasons that's not the right way to go.
Right. There's no really, medical necessity, really. That's the bottom line.
No medical necessity for the MDM on that. You're just doing an H&P. You're checking boxes. So I think you've got you've basically not met the coding or the spirit on the rules.
Yeah, basically do it on the day of the procedure. For those surgeons out there, do it on the day of the procedure. Simply write the short form HMP to satisfy the overlords at the hospital and the surgery center, and save that clinic day, that clinic appointment, for a more productive visit for another patient. That's the bottom line.
Yeah.
Yeah, we also had that question come up on the urology coding and reimbursement group as well. So it's a recurring question that keeps coming up. Can we do this? Can we get paid for it?
And you can see why, because it's a little nuanced, but I mean, hopefully we've given you at least some good parameters to go.
Yep.
All right. What's the bottom line here? What should they do?
If it's medically necessary and done outside the global, as long as they report it with the Z code as the first diagnosis, then it's reportable. And again, you're going to have to figure out your payers and how they handle that.
Most likely you'll get paid if you
Most
code it
likely.
appropriately. Yeah. If you're seeing the patient, again, the decision for surgery has already been made. You obtain preoperative clearance. The patient now comes back for the APP to evaluate this patient in a pre-surgery, pre-op clinic, goes over all the records to make sure that patient has done all the pre-op evaluation, make sure the patient is a candidate to undergo the surgery. Then with the appropriate ICD-10 codes, that is a billable event, billable encounter. Whether or not you get paid will depend on the payer. That's really the bottom line.
And on the other side of that bottom line is a routine clinic set up to reevaluate every single surgical patient, and billing for it would probably get you into trouble eventually.
Yes.
Yes.
Very good.
All right. I like that. Good discussion. Let's check out the next question.
I think we beat that one to death. Let's see. The second question also came from the Thriving Urology Practice Facebook group, and it's a recurrent question. And you guys have covered this in episode 26 of this podcast, and it keeps coming back. And this time, it came as a direct message to me via LinkedIn. And it reads like this: John, looking forward to bringing more value to your practice and innovations to stone treatment. And he included a link. A new paradigm for ureteral stent removal. Stent removing snare avoids crossing the sphincter, the external sphincter, the most invasive part of the procedure, minimizing discomfort. Reusable, easy to use, avoids a cysto setup, time saving. CPT 50386 with increased RVUs. And he lists the national reimbursement value, which is substantial, much higher than cystoscopy stent removal. I look forward to your posts. So basically, the bottom line is ureteral stent removal with a snare without the use of a cystoscope. And Mark, I know you have stuff to say about this.
Yeah. So, that 50386 code is actually in the ureteral section for a reason.
If I can give the exact definition, CPT definition, 50386, removal, open paren, via snare/capture, close paren, of internally dwelling ureteral stent via transurethral approach without use of cystoscopy, including radiologic supervision and interpretation. Back to you.
Thanks, John. Yes, and that is in the ureteral section for a reason, because it is transurethral, and it is put there typically because that, and the reimbursement is higher because typically you're using fluoro or some other type of guidance to put something up into the ureter to actually grab and remove the snare. Now, most of what I see, and I didn't actually look at this particular website for what was there, but what they're typically talking about is a little catch that they can snake into the urethra to grab the string and pull the ureteral stent out. That is not transurethral or ureteral. That's transurethral. So it doesn't go up into the ureter. So that code 50386 would not be appropriate for that circumstance. That really doesn't fit that particular or CPT code. So that is not appropriate in those circumstances.
Yeah, we got a lot of responses, and I know certain practices are doing it, and I just want to get this out there so that all the billers and coders know that, yes, even though you can bill for it, even though you may be paid for it, doesn't mean that it's the right thing to do.
Yeah. In this case, it's definitely not the right thing.
Yeah. All right. So I'm glad we put that to rest.
For now.
and I will also give, Scott, I'll give you the link to the AUA's Urology Place Coding Corner, how to code for indwelling ureteral stent removal. I'll send you that link.
Okay.
So people can read that.
Great. We'll put that on the episode page. Again, that's prsnetwork.com/118. All right. Ray, any thoughts on that?
No additional comments.
All right. Okay. Well, I want to let everybody know, since we covered those two questions, I want to let everybody know that the Urology Advanced Coding and Reimbursement Seminar coming up in December in Las Vegas and also in New Orleans in January. Registration, the early bird registration is coming to an end. So please get your registrations in. We will be sending out some reminder emails, but if you're listening to this, again, we'll put this on the episode page. We'll put links to the registration. Again, that's prsnetwork.com/118. So we'll have all these resources available to you.
If I could just interject real quick, I've been a student of you guys, PRS Network, for years. I just want to take this opportunity to say thank you for all the free content that you put out there in Urology Times. I read that thing like a Bible. Every time that it comes out in the coding corner, in particular, I read that section word for word for probably over a decade now. And I really appreciate all the excellent content, comprehensive content to help guide us so that we can confidently and safely do our jobs and do the appropriate billing and coding. Throughout the years, as I've been very fortunate to join all of you on stage at these UACRS seminars, I will run into urologists and they keep coming up to me and it makes me feel so good to hear this. They say, John, thank you so much for sharing the tips. And I really appreciate everything that I learned at UACRS, these seminars, because I'm using it years later. And just this past weekend, I had a urologist come up to me at a meeting and say, you got to go visit this guy, telling a new urologist, you got to go visit this guy. You got to go to the seminar. You learn so much. And I just wish I can just instill that concept and knowledge and idea to everyone, because you don't have to keep spinning the hamster wheel with grease under your feet. You can really get traction while you're spinning the hamster wheel. So UACRS is one of those. And thanks again for all you do.
Thanks, John.
Yes,
Appreciate
thank
that.
you.
Thanks.
It's been a rewarding adventure over the years, for sure. And the good news is for us, and as we do that, there's no shortage of questions, and we do have to answer the same question over and over again because the answers change as the rules change. So it's important to stay up to date on all that, and we try and get it out there every way we can to help urologists keep up with all the craziness that's out there.
And speaking of rule changes, thanks for the perfect segue. The public health emergency has been extended again on October 15th by Xavier Becerra. Can you tell us a little bit more about that, Mark?
Yeah, so this was as expected that they were going to extend the PHE for COVID, which allows us to continue to use the telemedicine and telephone codes to provide support to patients within Medicare. And so it's going to be interesting to see what happens over the next few months with COVID. And there are plenty of expectations that we're going to see a spike as everybody starts going indoors, and we'll have to see if they extend it once again after January. But they can only extend the PHE for 90 days. So it will expire again in January. But there is already passed a rule on the books that the rules for telehealth will be extended for 150 days after the PHE is allowed to expire. So, every time it goes 90 days, it's actually 240 days, right? That it gets extended for us to continue to do telehealth. Now, the other interesting thing, and actually I got this yesterday, so the timing is really good. There was a second bill that was passed by the House of Representatives in August on a 416 to 60 vote, so bipartisan support, that would extend the PHE telehealth rules through the end of 2024. And that is up in the Senate, and there are 60 co-sponsors of that bill in the Senate, pretty much ensuring that will pass. Now, the only reason it's delayed at this point in time is the budget committee that oversees everything that goes into the federal budget, if they pass this, is still, in the way that they have to calculate things, looking at this as a potential bump in Medicare spending. So they probably will not pass this before the midterm elections, but everybody feels like this is going to pass in the lame duck session after the elections. So we fully expect, with the votes that are there, that this will pass, and we will have the current telehealth rules for the public health emergency extended all the way through the end of 2024. So my advice overall is, plan for telehealth and really start leveraging telehealth, because it's here. Everybody thought it was for the future, but it's here for now.
It's here now.
Yeah, I would no. I would say continue to use telehealth because I use it pretty much every day that I'm seeing patients.
Yeah, I would agree, and that there are plenty of people like you, John, that are using telehealth. But I have seen number of folks that have taken it away. And when we talk about this, and I talk about this with groups around the country, the piece that I'm not seeing, but I do see with you, John, in the way you're doing things, is people aren't leveraging telehealth the way they should. They're using it basically based on patient demand. And it is really time to leverage this as a tool in your schedule to move things forward.
Maybe we can invite you back, John, and have a specific telehealth, what lessons learned, revisit that on a future episode and hear how you're doing it and see if we can't recommend some best practices.
Sure, I would love to do that.
All right.
And speaking of telehealth, I heard one subject matter expert in coding kind of casting doubt as to whether or not the way that some urologists or some physicians are using telehealth is appropriate, because we are using telehealth under the public health emergency, and the public health emergency is to mitigate the spread of a pandemic virus. Now that many states have pretty much said, well, we don't have a PHE anymore, but then federally we have a PHE that kind of covers our ability to deliver telehealth, telemedicine services, is it appropriate for us to continue to use telehealth under the PHE, utilizing some of the Section 1135 waivers?
So that's an interesting question in the overall scheme and scope of things. But I will tell you that I think we have some backing in the extension of the telehealth rules that has already been passed. The spirit of that was to continue to provide increased access to healthcare overall. So what you're seeing from the federal level is that they are using this event, we'll just call it, this major event that we're dealing with, as a way to expand access to healthcare overall. So I am not worried about the 1135 spirit there. The rules were softened initially for that, but the patient demand, the uptake of this, and the ability of Medicare to actually save money for patients and to the system has now been proven in the actual numbers that are billing Medicare. And the extension rules and all of that, and the arguments that support that, are all about telehealth being provided as an extension of what the physician can do. So I'm not feeling like that is an issue, given where the public debate is and what actually is being done in the spirit of this. They're just taking a political opportunity.
Yes, I agree.
All right. Well, great episode. Let's wrap this one here. Let's just go around the horn for some final thoughts. Ray, do you have any final thoughts?
No, it was fun. Thanks, guys.
Mark?
Yeah, so I guess my final thought would be, boy, I'd love to see you guys for an extended discussion on all this stuff in December in Las Vegas. Look forward to seeing some of you out there as I'm traveling around with all of this, and ultimately, as we keep preaching and all this stuff, your documentation, medical necessity, and everything that you really need to do is being looked at by a lot of different folks. So pay attention so that you can be paid appropriately for all that you do.
All right, John.
In the spirit of our first UACRS for 2023 being in Vegas, I like to say, try to not leave any money on the table. In order to do that, you really have to understand the rules of the game. Just like a lot of the folks who may not pay a lot of taxes, That's because they understand or they employ someone who understand the tax laws. When you're working in medicine, it would behoove you to understand the billing laws, the billing rules, and the coding rules. Those of us who understand these coding rules understand the legal and appropriate use, and also understand the spirit of these rules so that you can appropriately maximize your revenue and not leave money on the table.
Well said. Well said. All right. Let's wind this one up. Take us out, John.
Happy coding, everyone.